Slide
the mouse.
right?
You can just use the mouse. Yep, and just click on it. Yeah, and you can see it if you want to.
Maybe I don't know if I can click and stand both.
Oh, well, you can just hold it and just click it. You don't have to.
Oh,
stand
really?
on it. Yep.
Oh,
That would be the other side. There you go.
Oh, that's the right here. Oh, now I'll really go back. I don't need to go back. That's fine. I'll just go forward.
Perfect.
Thanks.
Yep.
Get out of your way so you can all see. But I'll go ahead and start. My name is Janet Helkeman, and I live in Omaha. I work for MMIC, who is your professional liability carrier. And we cover the hospital, and in this particular presentation, I'd like to bring up a lot of things that are relevant to the claims that we see that have to do with hospitals, you know, our own claims. And as well what we see nationally when it comes to documentation, what are some of the problem spots. And so what we'll do today, I think I've got, here are the discussion topics we'll cover today. We'll talk about identifying how documentation really does play a very significant factor in claims. We'll talk about the key factors in quality documentation, which you already all know, but it's always good to have a review. And we'll talk about the appropriate ways to document high-risk situations. And that, you're gonna recognize what they would be. Chain of command, the things that most often come up with claims, you'll recognize them as we go through them and think, well, yeah, that makes sense. They would be the most high risk. We'll also talk about identifying strategies to just ensure that quality documentation is in there. Just as a review, let's talk about the purpose of it. The purpose of the health record, sometimes I think that it's so easy to forget. Why are we doing it? You know, what is the purpose of this? It's actually a legal record that the hospital, of course, is required to have for a lot of different reasons. For the business, it supports the decision analysis. It's important for its patient safety to make sure there's continuity of care and generates data for any kind of quality purposes you have going on, for compliance. Of course, you've got to have it for billing. Here are the most common hospital claims that we see that, and as you can see down here, documentation is one of the most common things. Now the word failure to, I hate that word really, but that's just a legal term that they use. Failure to follow the standard of care, failure to use equipment responsibly, failure to assess and monitor, communicate, document, or act as a patient advocate, or follow the chain of command. So as you can see, documentation is one of the most common ones we see in hospital claims. I think this is interesting. We have seen an increase in this, failure to act as a patient advocate. And I'm not sure why. But that goes back to not feeling comfortable calling the doctor if you see somebody's going downhill and you truly think that they need some help, or a higher level of care. Don't get a call back, and maybe they get yelled at over the phone, who knows why, but they choose not to pursue it, even though they really feel like there's a need. So what we sometimes forget is that, of course, we're the patient's advocate. We're not the physician's advocate, we're the patient's advocate. And sometimes, and it could be that, you know, with new graduates or somebody that's not really used to the situation, they may feel intimidated and let it go. So there's no wonder that it does play a significant factor in professional liability claims, because the record is the source of communication, coordination of care, as we already mentioned. It's a source of reliability. This is the stickler right here. We have to rely on it because there's nothing else we can rely on. So that's important. The thing we all have always heard our entire lives, our careers, is, you know, in court, the medical record is the care rendered, and if it isn't in there, it didn't happen. Now, if you did any particular type of care and it's not in the record, it's not that we won't defend you. Of course we'll defend you. It's just that it's incredibly difficult to win if you don't have the proof. I mean, that's what it gets down to. And this is just an example of a 26-year-old man that came intoxicated to the ED. And in this particular case, when he first came in, the nurse really did do a triage, and he was in kind of a holding area. There wasn't a room available for him yet. He was in a holding area. And the bottom line is that she said she did go in and take the vitals every 15 minutes, but there were no vitals there while he was taken in the medical record. So by the time he got into the actual ER room, he was very ill, he wasn't breathing, and obviously there was a problem. He ended up dying. And what the nurse said, what her defense was, she goes, I know I did. It wasn't in the record, but she said, I know I did it because I always do it. I mean, it's just a habit. I always go in and check on them all the time. And for what, and you know, in a lot of cases, it's very understandable. When you're in the ER, you're trying to keep your head above water. You're trying to deal with the crisis, or crises at hand. And it doesn't always get documented. But unfortunately, it was up to the jury then whether to believe her or not. And unfortunately, they lost that case. Not saying she didn't do it, it's just that there wasn't proof, bottom line. Talk about red flags. And when we talk about red flags are something that the plaintiff attorney looks for. And as you know, when a family or a patient is upset with something that happened, they may believe something happened that shouldn't have happened, or there's some substandard care that occurred, and they take it to a plaintiff attorney. A plaintiff attorney does not want to take it unless they're absolutely sure they can win. The plaintiff attorney has to put a lot of money up front, you know, to get the case started, get the reviews going, and they really don't want to bother with it unless they are really sure they've got a good chance of winning. What they have to go by, first of all, they get the medical record. And when they go through the medical record, they look for red flags. The more red flags they can find in the record, the more apt they take the case. Let's say there was some problem with surgery, but it's not just the surgery they're looking at. They look at the entire record, and they look for anything that's inadequate in that record, because then they can pile on, and it makes it look like, wow, this was sloppy care all the way around, not just in surgery. So it just beefs up their case, and they're more likely to take it if they've got more than one thing to look at that looks inadequate. Now here are some of the most common red flags that they look for in the chart when it comes to hospital claims. Medication and treatments ordered but not documented. These things will not be a surprise to you. Lack of patient teaching and discharge planning, you know, that's getting bigger all the time. Any kind of charting inconsistencies. And I'll go into that a little bit more. With electronic health records, we have new emerging risks that we didn't have before. And inconsistencies are one of them. Lapses in time, references to an incident, reported discussions with risk management. Well, that's, of course, red flag. They're telling them something happened there that shouldn't have happened. And, of course, lack of informed consent. Jousting, very top one, battles between healthcare providers. Jousting is a very important one because that tells them there's finger pointing and blaming. Another red flag. And you know, that should never happen. It happens, I realize, you can read it, you can see it and hear it, but it should never happen. Late entries aren't labeled correctly as such, or else maybe they're in there and clearly only there for a self-serving reason. Fraudulent or improper alterations in the record. If there's anything like that, then you just automatically lose the case because there's nothing you can do to defend fraudulent or improper alterations. I mean, that's just you know, it's kind of the worst thing that could happen, really. Or any kind of destruction of the record, just absolutely improper behavior. Here's what it's supposed to be. The medical record is supposed to tell a story. We're supposed to be able to look at it, and when you look through a medical record, you should know what happened to that person from the time they got there until the time they left. That's becoming increasingly more difficult with electronic records. But there's things we can do about it. The things we have to keep in mind, regardless whether it's paper or electronic, all these things that we were taught many years ago inconsistently have to all be there. And for it not to be accurate or objective or still illegible at some point, and maybe it's electronic, maybe it's legible, but maybe the grammar or the spelling is so bad that it's still causing a problem. So, whoops. I'm going down. Okay, there it is. Okay, let's start with accuracy. There always needs to be two identifiers on the patient record. Reread the entries before you're done with them to make sure you know what you put on there. You know, just on a daily basis, look at what we text and find out what we end up texting. We have to reread everything. Here's some real life examples. It was in a chart. As far as inaccuracy, the admitting note was dated 10/28. First progress note, though, was dated 10/26. You know, just kind of careless errors. The resident says it's a 4-year-old male. The attending put it was 4-month-old male. Okay, maybe this didn't matter in this care, but this is just one of those red flags on top of everything else. They're like, wow, this place is sloppy. And you know, they'll make a big deal out of it, even though it may not have had any direct result of poor care. It's something to latch on to, one more thing. But of course, this would be a very big deal. ER note reads, you know, fractured on the left hip. The admitting note says it's the right hip. Of course, that would be very serious. And the bottom one, call lights in reach, verbalizes no complaints. The patient's comatose. And these are just some funny things that were actually in records that are just for laughs. Large round stool ambulating in the hall. Dr. Blank wants to sit on her abdomen, and I agree. Patient has left white blood cells at another hospital. She has no rigors or shaking chills, but her husband says she was very hot in bed last night. And the patient has 2 teenager children, but no other abnormalities. Now, this is something that those in your facility that do transcription, I don't know if you use Dragon or what the system is that you use, but this is examples taken from transcription. Some of them are kind of funny, but some of them do make a very big difference. Okay, that's just kind of funny. We know there's no baloney amputation, but this is a big deal. You know, it's transcribed as had no carcinoma, but it's dictated as adenocarcinoma. So that is serious. Patient had a Pabst beer today instead of a Pap smear. You know, it's a little humorous. But the problem with this, what we're seeing, is that what's happening is, I don't know how you do it here. Some places have whoever did the dictation initial it or sign it off, as if they read it. The problem is they're not making the changes. When they're doing that, that's saying they did really look at it. They didn't just touch it. And maybe they're in a hurry, but for whatever reason, that is something that's happening, is that they're, you know, you've got to look for things like this. You got to, some of these things aren't serious, but some of them could be. As far as consistency, the format, everybody needs to do the same thing. We have examples of physicians that don't like part of the electronic record, so they skip the part they don't like. Yeah, it just doesn't work. And then somebody ends up getting hurt because they didn't get a warning, or they didn't, you know, they decided that they wanted to write out on a pet, you know, prescription. They didn't know somebody was allergic to aspirin, or, you know, whatever it was. There are all kinds of examples about that. So we all need to use the same thing and do the same thing with the process, of course. And we have to be always reminded about the 5 senses, that we have to really be objective about it. gotta keep subjective statements out of there. The personal opinions still have been creeping in, and it's just kind of an attitude, a language that maybe people don't know not to use. And some examples of that might be drug seeking, whiny. Sometimes they put a lot in the record about people other than the patient. If it's a child, a lot of times they'll put comments about the parents, what they're doing in the waiting room, or, you know, what goes in the medical record is only about the medical treatment and the medical care of the patient, not about anybody visiting, and it's not about, you know, anything other than that care of that person.
I would like to disagree with that. There's oftentimes
There's a
when
lot.
we need to document
The
things about
psychosocial.
psychosocial parts of the patient's care, and it does affect patient's care, especially with children. If parents aren't, you know, don't interact with the child appropriately, those kinds of things.
I hear this a lot, especially when people bring in kids into the ER, for instance, and that there's maybe some abuse or neglect suggested. But it doesn't belong in the record what the parents are doing next door. Or they're, you know, if you document in a factual way what you see in here, that's all that's needed. What gets into the problem is the subjectivity. And you can just, by reading it, you know somebody's got an opinion about those parents, and it's not a good one. It goes beyond objectivity. So that's fine if it directly has to do with that patient's treatment and care, and it's objective, that's fine. And I'll give you an example of what one was. It was a child in the hospital, and someone was upset about what the patients were doing in their free time. You know, they were on their phones, they were doing this, doing that, and see, we're not doing an investigation. We're not doing the social work, we're doing the medical part. And so, as long as it's factual and it has to do with the care and treatment of the child, that's fine, just so it's objective and it's not subjective, and maybe that's not clear. You know, you're probably doing a fine job.
I don't know that I'm doing a fine job, but
But that is I know that that's part of nursing. I mean, I understand what you're saying. I mean, we've always been taught to be alert to those types of aspects of people's care. Now, tell me where, maybe if I understand, like where in the record would you put something having to do with psychosocial assessments or something?
Like when we have a newborn and who's holding the newborn, if mom or dad, if they're bonding, if
Sure.
there's good eye contact and that kind of stuff.
And that would absolutely relate. And do you have something in your record that is that on, is that something you free text, or is that something in part of a template, or?
We just free text it.
free
Okay.
text, you know.
Well, there's bonding on our
Yeah.
assessment.
Oh, yeah.
Is there?
Yeah.
Yeah.
Yeah,
That-
on the mom's.
Yeah, I'd say that makes sense. Here's some things that always have to be, you gotta make sure you got them in there. They're usually in there, dated and timed and signed. We find more and more that it's very important to have that education regardless of what you're doing. Discharge planning, or if you're doing education regarding medications, always important to be in there. This, of course, as you can see, is just an example of, this was in an ER, and the point of this is that here the domestic violence screening and the alcohol screening was not answered, but the tobacco screening was. And what they can do with that is blow that up into something that's, you know, point out, oh, you didn't ask this, what else didn't they do? What else didn't they do? If they don't do this, what else don't they do? Do they just do what they want to do? Do they just skip over some of the care because they don't feel like doing it? You can imagine that. There may be some very good reasons why that didn't get filled out. That's fine, just write on there why not. Patient refuses to answer, or patient is too ill to answer, or, you know, whatever the case may be. And so luckily these days are over, and as I mentioned, now the thing that we really have to be more careful about is, when we are free texting, to make sure that it makes sense, grammar, spelling, we still have to be somewhat careful about it. This is hard to do, I know, and it's maybe probably the nurses do a better job than the physicians do on that. High-risk areas are what we're going to talk about next. This is when adverse events occur. Let's say, for instance, that you're meeting with family, or I don't know how it happens, that what your policy is here. Are you involved with that usually, Jessie? Say, for instance, is there any kind of formal apology and communication procedure or policy?
Yeah, we have our grievance.
Where you
So
sit
she-
down with a family or a patient and talk to them about what happened or what you know, or
Like
say
if an
maybe,
incident happens, is that?
yeah, like say maybe a medication error.
I think the nurses kind of talk to them if something happens.
I don't know that we have a formal
Yeah,
policy
I don't
though.
think.
Okay. Bottom line with this, as with everything else, when you're documenting who you talk to, you don't have to go into a whole lot of detail. You just let them know who you met with, who was there, and let them know generally what you talked about. And this may not come up that often for nurses, but in some places it does. Depends on what your process is, really. This is an important one that I know all nurses have to deal with, and this is notification of changes in conditions, what I mentioned earlier. These are the important things to make sure that are in the documentation, the time and method of notification. If you're concerned about a patient's well-being and you're trying to call a physician to let them know, document what time you called them, what time they called back, orders received, what time you received the orders, and when the orders were implemented. But here's the problem. Let's see if this is, yeah. Say that doesn't happen. You don't hear back, and you don't hear back. And you feel like it's really important. You know, nursing is really more of an art sometimes. We get caught up in tasks, but we really do have to trust our judgment. And if you feel strongly that this patient needs more care, or you need to get a hold of somebody and the doctor's not calling you back, I don't know about you, but I've certainly had doctors tell me, do not call me again. You know, it may happen less than it used to. But they certainly been told that. And if you feel strongly about the need for a change of level of care or medication or anything along those lines, then you need to know the chain of command and to document that. And when I talk about chain of command, documenting it, what I mean by that is, let's say for instance you try to get a hold of a physician and you tried once, no answer, no answer, no answer. Okay, you write the time you tried and put in call to whatever doctor. And then if you do not get a call back, what you can do is you can put the time that you called your supervisor or whatever your policy is here as far as chain of command. Whoever you're supposed to talk to next. If it's your house supervisor or if it's your charge nurse, whoever it is in the case here, you can put down, at 2100, I tried to call Dr. So-and-so, or put in a call for Dr. So-and-so, and then no response in 20 minutes, and you feel relieved that you need to get a hold of someone. Maybe you try again. You write in there that you attempted to contact the physician, and then if you still don't hear back, then you put the time that you contacted whoever it is you contact, your house supervisor, or whoever it is. So you just so it looks, obviously, that you tried. It's not that you walked away from the situation. And we talk a lot about refusal of care because I don't think that happens enough as far as documentation. When we do an informed consent, or when the providers do informed consent, that conversation about the benefits and risks of what what procedures they're gonna have happen. We talk about that pretty frequently. What we don't talk about very often is the refusal of care. Now, once they learn the risks and benefits, maybe they don't want to have it. Maybe they don't want to, maybe they don't want to, I'm trying to think what they don't want. There's some procedure that you're gonna do with them that they don't want you to do. Okay, they do have a right to refuse it. But what you do in that situation is you let the provider know they've refused it. You document when you told the provider. And you also have to let the patient know, or the physician has to let them know. Somebody needs to let them know right up front what's going to happen, or what could possibly happen if they refuse that treatment. As an example, this is an actual case having to do with someone that didn't want the pulse oximetry because there was beeping all the time. And I believe, if I remember this right, this was in this post-surgical patient, and they did not want it, and the nurse, they took it off. The nurse knew they didn't have it. The respiratory therapist knew they didn't have it. The physician did not know he didn't have it on, but they got into some trouble. They did not contact anyone. This patient got into a respiratory problem, and then this is how it came out that he didn't want it on. Late entries and addendums. Usually we call addendums anything after 48 hours. Up until that time, it's usually called late entries. I don't know how important that is. But it's just that I've heard both, and that's just how it's distinguished, I guess. Late entries are always appropriate to do if you're going down the road and you think of something you forgot to do. A lot of times that happens when you're home, then you think of it. And the next time you come in, you do the documentation. The only time it gets a little sticky is if it happens to look like you're covering yourself after there's a claim filed. You know what I mean? Maybe you hear your neighbor down the street talking about so-and-so was upset about the care, and you think, oh my gosh, I wonder if I did what I was supposed to do. And then you go in and look at it, and then you make changes. That's not appropriate, of course. And so that's not what we're talking about. Anything that looks obvious that you, obviously covering yourself because you heard there's a lawsuit, not a good idea. And when there were paper records, I don't know if you used to do that here, but when there were paper records, as soon as we heard that there was a complaint, potential lawsuit, we locked up the record. Because if we didn't, the physicians would go in and make changes. And so it's just, and now with electronic records, oh my gosh, you can tell every single thing that happens, of course, and when it happens exactly. So it's obvious that somebody's trying to cover, but it's always important, if you've forgotten something, go ahead and go back in and put it in. This is what I just talked about, anything that raises a suspicion, why'd you go in and do that now? I think I've got a good example of that coming up. Again, the record is supposed to tell a story. Now, we've got some emerging risks that have come with electronic health records, and this is the number one. This is just in one given year. CRICO is the name of, we're partnered with CRICO, and that is a Harvard-based, all their healthcare systems are included in the claims, and then they've got about a base of 300,000 claims right now, and we put our claims in with them as well to get a good idea and dig down to find out information like this. When it's an EHR-related issue with the chart, what's the biggest problem? The biggest problem is incorrect information in the record. And in 1 year, 2013, for them, what they found was 61 million that paid out due to that one cause. Okay, this is a risk roadmap. These are the things that they have found that cause the most problems with claims and lawsuits. This is strictly related to electronic. Copy and pasting alerts, workarounds, shortcuts, and altering. Copy and pasting is some information, some details. This is related to physicians. It shows that a great deal of physicians do a lot of copying and pasting. What's the problem with that? Problem is that that gives you outdated information. It just goes on and on perpetually. It could be not only redundant, it could certainly be incorrect. You could do some false billing because of it. Now, each of these is a post-op patient. Each is a different day. It's hard to read, I'll read it here. This is a physical examination. She's afebrile. Vital signs are normal. Abdomen is soft and non-tender except around an incision. The dressing is dry. She has no abdominal distension, and her urine output is good. Now, it says the exact same thing this day, and this day. And she died. And this is what they got. And so you can see the problem there. Alerts and warnings. Do you get alerts and warnings for anything? Is it primarily physicians?
Medication.
So when medication order entry, there's alerts.
Okay. The problem with alerts and warnings are that people are getting kind of alert fatigue. You know, we used to talk about that with the alerts for all the sounds. You kind of get fatigued because you hear all these sounds going off. And same thing with this. This is an example of the problem with it. The problem is, you know, of course, the alerts and warnings are there for a reason, and when they're not paid attention to, you know, things can go wrong. The thing that bothers physicians a lot of time are that, you know, maybe they've given this patient the same medication for 10 years, and all of a sudden they've got a warning. And the problem is that now, because we're using electronic records, they can tell whether you looked at the warning, and they can tell exactly how much of a partial second you looked at the warning or didn't look at the warning, how fast you clicked through it. So what has to be done is really, you know, you have to balance it out. When you get too many warnings, chances are the warnings won't go away. I doubt that they'll decrease those. Workarounds happen when people don't want to do the entire process. Like I mentioned earlier, when they're to write out the prescription on the pad, they don't get the information they need. And there's all kinds of problems that come up because of it. Shortcuts. Here are the most common shortcuts that are causing problems with the records: autofills, drop downs, and default settings. Here's a case example of an adult version of medication that's auto-refilled. It's penicillin, but it was, the patient was actually an infant, and it was an auto-refill for adult. And drop-down boxes causes problems as far as names frequently, because a lot of people have very similar names or maybe the exact same name. When you've got the drop-down box, it's so easy to hit on the wrong one. This is an example of a default setting for an opioid. And this setting, they couldn't figure out why there's so many overdoses. And they looked into it and then finally realized, you know, the setting that they had was really for someone that would have been tolerant of an opioid. But if it was someone who was not tolerant of opioids, it was too much. And so after some investigation, they found out the default setting was really the problem. Here's an example of some cases that were problems with templates. This is very fuzzy, but it says functional assessment within normal limits as evidenced by ability to stand and walk with a steady gait. And look, the patient is paralyzed. No change in the patient's usual level of function. So, you know, it doesn't make sense. The second case example would be a 2-year-old well visit, and it was really a template for an adult, so that didn't work. we already talked a little about altering records, and there's absolutely nothing that they can't find. Here's the example that I mentioned. This was an example with a nurse. This was the timeline of events, 1659, original fall assessment. A minute later, patient falls. A minute after she did the assessment. And then they can see at 2110 there was an edit to this, changed it to before the fall. And 2140 documentation of the fall. So this got, they clearly could tell that this got changed. This is an example of patient was discharged with a skin wound, and the surgeon had testified that he reviewed the wound cultures in the record, and he assessed them as being insignificant. But the problem was they did an audit trail on that, and of course found out that the culture results came in after the discharge actually, and the surgeon never opened or viewed the culture results. So as I mentioned about the red flags, the attorneys are looking, they're tacking on problems with the records and the documentation just to make their case stronger. What can we do? Some of the strategies that we can do are just really verify that documentation is for the right person, that you're entering the correct data in the right place, you're not leaving blank fields. Document as you go as frequently as possible, rather than trying to catch up and remember what happened. And here's one that we don't talk about enough, being specific about the patient. I don't think that we talk about that quite enough. Being specific about the patient, that is what of course is sometimes missing with electronic compared to the written record, the paper record. And as long as you can do the free text, that always helps. Anytime you can bring that closer to, to show that you know the patient, you spent time, you've assessed, and it's in a personal way rather than the copy and paste way that we saw, is always good. And reading previous charting as well is important. All these things take time. They don't take a lot of time, but they take more time. And it does take time to read what somebody else has done. So, well, our goal is that it does stay meaningful. Electronic health records are here to stay. It's not going to change, and we're going to see more and more benefits. But it's a rough patch getting through it, and we're going to have to continue to work with vendors, make sure that everything is what you need as healthcare providers to get the information into the record that you can. And it can be a bit of a struggle. And Europe, for instance, is about 10 years ahead of us as far as medical stuff. They've been using electronic records a lot longer than we have, and they went through the exact same thing and had the same complaints and the same frustrations and the hair, pulling your hair out kind of stuff, just because it's getting used to something new. And it certainly can be frustrating. And these are just some things I'm sure you already know as far as protecting your password and not tampering with the documentation, logging off the system appropriately, all the things that you're already told to do. And I have this up there because I just wanted to say that I don't think that are you all nurses, by the way? All in the nursing department? I just wanted to say that I don't think it happens often enough that you get a lot of credit for what you're doing. And I know, especially, it's a tough job, it's difficult, everybody's exhausted. But I don't know if you know how important it is and how valuable it is to the people that you work with. But I just want to say thank you for doing that, because I don't think you hear it enough. I think a lot of days you probably don't hear it at all. But I think it's really important. I just want to commend you for what you're doing. Does anybody have any questions, anything about documentation that we didn't touch on, that we should? Anything that, if there's anything that I usually bring up?
The
Anything
attorney,
in your- I'm sorry.
the attorney yesterday talked a lot, quite a bit about refusals of care,
Mhm.
so that if, you document non-compliance, offer the patient the opportunity to write a refusal, to say, you know, I refuse to wear the oxygen, or I refuse,
Uh-huh.
you know, whatever.
Right, he says flip over
Uh-huh.
to use the MA, he says it's not used enough.
Right. So, that's just something
Yeah.
we talked about yesterday,
Mhm.
because if the patient refuses it, you're off the hook, you know, but you do have to
Right.
fill out the form to say, this is the benefit of what I'm trying to get you
Yeah.
to do, and this is what's gonna happen if you don't do it, and then have them sign it. So,
Yeah, I think it's important, and I think we also, as just healthcare people, I think it's good to remember they do have the right. We have the right. And I hate the word non-compliance. It's as if you've done something horribly wrong. If you didn't agree with the treatment, you're non-compliant, like you're difficult to deal with or something, or if you go to get a second opinion, it's, you know, and we need to improve on that. And we need to remind ourselves is that they can refuse. It's their decision about their treatment, their body, but it's just that they absolutely have to know the risk that they're taking if they don't.
Sometimes I feel like providers need to be filling that out a little bit more, that refusal of care. 'Cause if
If-
people-
if they're
If
there,
we provide it
but-
to them, I mean, if we,
What?
yeah, if they're there, I mean, if we pull it for them and give it to them, then, I mean, there's the conversation sometimes, I think, needs to be from them as well regarding the benefits and.
Yeah, I agree.
That would be, I think it's a great idea. I mean, it would be a nice habit to get into, that,
Yes, in the perfect world, it would be
Can always strive to that.
yeah.
Yes, you can.
I know yesterday, some of the girls, I went to the meeting yesterday, had come upstairs and were talking to us about some of the things they had heard, and they were talking about, like, the times, like on our documentation. Have you ever had that conversation with them about this? They were talking about like how, like when we pass our meds and we go over and we turn it on the computer, and then we come out like from the room and we document on our activity flow sheet that so we passed our meds or whatever, however you document it, and then those times don't match because you gave your pills 5, 10, 15 minutes before you went down and charted on the activity flow sheet in your computer or whatever.
Yeah.
They were talking about how that's not, like they were told yesterday that that's not actually.
You don't wanna do the specifics, you can say med pass done with assessment or whatever, but it's saying the morphine given, this given, he said like refer to your other documentation, so like refer to EMR for meds or stuff like that,
Okay.
because then you're not saying that you gave them at that time, it's saying I did give them, I'm referring you to the EMR so you can see exactly what I gave when I gave them, if that makes sense.
Okay.
But Cheryl and I talked about that yesterday.
Cause I mean, I do that, I'm like, oh crap, I do that all the time. I mean, I'll pass meds and then I come out and I'll chart and then you don't have time to chart an activity flow sheet. And so you kind of guesstimate, you know, I was in that room about 9-ish. And, you know, when I passed all my meds and blah, you know, blah, blah, blah. But my times, I mean, they wouldn't match up I mean, you know what I'm saying?
But
That's probably not as important as like when you started code or when it was
Right.
called that they were dead. I mean, if you're passing meds and just doing basic
Right.
Yeah,
stuff,
the
it's not gonna
specifics that
be.
you're saying, like the pain, you know, that kind of stuff, so like if you're giving a pain med, you'd say, refer to EMR, not, I gave 2 milligrams of morphine, happens, you know, it's just not, it's being specific in your activity flow sheet, but with stuff like that you're already documenting somewhere.
Okay.
And like specifying more, making it more patient specific, absolutely, but just not repeating yourself or
I really
crossing
like
lines.
that roadmap kind of thing in your activity flow sheet where you're doing your narrative to say, refer to this or refer to that. You know, when you had a paper chart, you have this bundle of paper and you can look through it and you know you've seen everything. With the electronic chart, it's possible that there's information in some of our flow sheets or someplace that you might not look if you didn't know there was information there. An example is, you know, we typically put on vital signs flow sheets, and I recently opened a chart and thought, this patient doesn't have any vital signs, but they were on the neuro flow sheet. And I didn't find that until I read on the activity flow sheet or the critical care flow sheet to refer to neuro sheet. And, you know, so those kinds of little tips,
That's a great idea.
references and
But I haven't
maps.
heard anybody say that before, but that would solve a lot of problems.
And like your
Right.
assessments, because someone asked about that yesterday too, you know, they said that they put a lot of their initial assessment in the activity flow sheet. And I said, don't, refer to your activity, like, refer to my initial assessment, because, you know, that's just,
Are
you're
you
not
saying
double
they would
documenting.
repeat it?
Right.
And then it might not be the same.
Exactly.
Right.
Yeah.
So that's
That-
it, yep, I said, make
yeah.
a note.
Besides which fact,
Why
if
repeat
you've
it?
already said
Yeah,
the lungs are
that's
clear,
just
why
it.
are you gonna say the lungs are
Yes.
clear?
Mhm.
You know, and so,
Yep, it's just
referring
getting rid of
to
the
it.
double documentation, yep, and just referring to where it's already documented.
Okay, that's good.
Yeah, so that's probably what they were talking about, because we
That's-
did talk about that yesterday.
Yeah, that's good to know.
That would really be helpful.
I'm glad I asked, no.
I'm just curious, are you doing anything as far as, are the providers, or are you doing anything with text messaging, or do you do anything with?
we have a encrypted text message service that we use occasionally to provide information to the doctor on call.
Okay.
But
Is there
they're not,
patient
text.
information?
they're not texting with patients, so. Is there patient information? Yes, sometimes. But
Only
that's
reason
why it's
I-
encrypted.
Yeah, but how do you then get that into the medical record?
You don't, it's like a
But it's
phone
like a
call.
phone call. So if you contacted the physician.
Well, if you contact a physician, you can write in there that you contacted them.
And
Right.
same thing with
So
So
it's
that's
the
like
same
a phone
thing.
call.
Right,
And so with the text, how you do it is you say you texted them the information, or
Or
texted,
just contact them.
yeah.
because that is like, well, I'm just curious how that happens. I don't know how this is gonna work out, because should be just the same as the medical record. Are they gonna keep their phones how many years, like we keep the medical records?
Why would it be any
Why
different
would-
than a telephone call though?
Because it can be lost.
But if I take a verbal order from you, that's no different than whatever, and it's what I heard and I put the order in. You know what I mean? So why would you need to keep that text? Because we can't keep you know what I mean, what you said to me.
Right, but it is in writing, okay. I just think it's challenging. What some places are trying to do, first of all, I don't think anybody is condoning using texting for any kind of patient information ever. But it is used frequently for scheduling and, you know, stuff that doesn't have very specific patient information in it is fine.
We probably use it once or twice a month, so it's not really
It's
something
not,
you
it's
can
not
get into.
a regular thing.
And it's probably
It's like
not specific, it doesn't say Joe Schmo has blah, 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 but rather there's a patient in the ER and we need to come see that, you know.
Or they drew a H&H on them and we
Yeah.
give them
Right,
their
but telling them
numbers.
to come to the ER, that wouldn't be patient information anyway.
So,
And so that's just thinking in the future, the problems that we're gonna have, and I know in Omaha, here's what's happening, is that, you know, they're doing appointments, you can do an appointment over Skype, and then you hear these horror stories about, okay, shine a flashlight in your, you know, or look at the rash, or, you know. it's kind of scary. And when it comes to phones and Skyping, and it's like a whole new world. You know, we're just, like I showed you, the claims having to do electronic records, we're just starting to see them now. We don't know what's gonna happen in the future. It's the same way with texting and all the new ways to communicate. We don't even know what's going to happen. But the bottom line of those texting, text is the only thing that is a real concern. If there's patient information in it, how it gets transcribed into the medical record, and if it's accurately transcribed, if it's the actual thing that happened or the actual thing that's said. Technically, that phone should be kept as long as a medical record. If you're gonna be, you know, if there's actual patient information on there. And so it gets it just gets hairy. You know, I don't know the answers to it, but I just know that it's causing some issues right now. Because what do you do with the phone? It doesn't hit the things that you're supposed to do as far as documentation. If you've got part of it here and part of it there, it's not like words on the phone exactly, because it's in there.
The encryption service that we use does not, the information never arrives in the patient's, or in the other person's phone.
It doesn't. How does it happen? Exactly.
I'm not the IT person.
Yeah, I was gonna say.
Well, obviously, I'm not either.
But it's like both sides have to kind of log into it.
Okay.
Right.
And then, so like,
And there's-
Cheryl and I can send each other messages, and I would get like, if she sent me one, I would get a notification on my phone that you have a message in Click, is what it goes, and then I would have to use my secure, whatever, to log into Click. Yep. And then I would see it, but it's never like on my phone, and then the second that I get out of that app,
It's gone.
Yeah, it's gone, and like, I would have to log back in. It never saves your password, but you can't do that, you can enter it every time.
Gotcha. That sounds really good. And I can see where that would be convenient. And you're not using for orders? Or if you do, if it's anything close to some, if it should be in the medical record, you'll get it in the, it'll go in the medical
Yeah.
record.
Yeah, because then if, like they were saying, if somebody contacts the physician via text, they'll say contact physician, and if they get an order, it's entered as a verbal, essentially.
Sometimes, I tell you.
Yeah.
Do the physician, do the providers like that? I mean, do you guys like?
We really
using
only
it?
have one
I was
provider
gonna
that
say,
even
we
does
only
it, I
have
mean, it's
one
not
that
even
even
an
uses it.
issue.
So that'll probably change in the future, the younger the providers get, the younger the providers get, the more they'll feel comfortable with all of it, I'm sure. That'll be good. Well, anybody else have anything else that we should cover? I sure appreciate you coming and
Thank
taking
you
some
for
time out.
coming. It's a long ways from home.
I love coming out here, and I've been wanting to come out for a long time. Long time. Year and a half. So. Well, thanks, everybody.
Thank you.
Speaking of actually reading my notes, I don't remember rereading any